Thanks everyone for having me. Today we'll be talking about the trials and tribulations of traumatic brain injuries. So this lecture is a little bit of a joke. I feel a little bit like the man behind the curtain here because traumatic brain injury management is extremely easy and you're all going to find that out soon. So there's no reason to be scared about it or nervous about when you have to do it. We just have to manage all these parameters. All of our guidelines are exceptionally old. I always enjoy when I come to these lectures and hear about these guidelines that are like 10 of them were published within the past 6 months. This is a picture of me last time our guidelines were developed. And everything you need to know, all of our treatment goals are completely normal values. So you don't have to remember anything. When we do make updates to things, our GCS initially created in 1974, you can see the amazing updates that were made in 2014. Useless. And whenever we publish things on prognostication, also garbage. What we learn, worsening GCS has worse outcomes, age has worse outcomes, and bilaterally fixed and dilated pupils have worse outcomes. Thank you, Brain Trauma Foundation. If you fall asleep, just remember this one slide. Cerebral perfusion pressure equals MAP minus ICP. The brain needs blood. We do that by delivering blood through our arterial system, and we want to reduce our ICPs so that we can have more blood in the brain. That's all you need to know. You can fall asleep now. All right. So what is cerebral perfusion pressure? It determines the amount of cerebral blood flow. Again, the only thing we care about. Decreases in perfusion pressure causes decrease in blood flow, and that causes secondary hypoxic ischemic injuries. We can't change the primary injury. You hit your head already. There's nothing we can do about that. But we can prevent secondary injury from occurring, and that's all we focus on once we're in the hospital. Intracranial hypertension, basically elevated ICPs, causes decreases in cerebral blood flow. And we know that patients who have sustained elevated ICPs over 20 have worse outcomes. So the Monroe-Kelly doctrine, if you remember this, is basically your head is a rigid box. You have about 20% brain, 80% brain, 10% CSF, and 10% of blood in your vasculature. When you start getting a mass lesion, that blue box, you first decrease the amount of CSF. As that mass lesion gets bigger, you can't reduce the amount of CSF anymore, so you start decreasing the amount of blood in your vasculature. And then as that mass gets even bigger, you start to reduce the amount of brain in your head by herniating. This guy, if you're wondering what that picture was, he already had a hemicraniectomy. His ICPs were so elevated that brain started squirting out through the suture line like toothpaste. And in case you're wondering, brain smells terrible. Dead brain, please. Normal brain doesn't. So this was a case that we had on July 1st, 2023 to kick off the new year, around 10 o'clock in the morning. A 30-year-old male, no past medical history, was a construction worker, fell about 25 feet off scaffolding. He does this all the time. GCS was reported to be 5 in the field. Right people with 6 millimeters non-reactive, left people with 3 millimeters non-reactive. He's got profuse bleeding from his mouth and nose, his brain coming out, and here are his vitals. What do you want to do? Anyone? Excellent. I stole the screenshot off the YouTube video. So yeah, all we care about, right? No matter what your lecture topic is, the first thing you're always going to do is your ABC. And then what's our goal in the ED? Our goal is to reduce secondary injury. We talked about that. Secure the airway, prevent hypoxia. Our blood pressure goals, people always ask what your blood pressure goals. Here they are, pretty easy to remember. Just remember greater than 110, right? Easy number to remember. If you can't remember that, remember greater than 100. It's dichotomized a little bit by age. There's not great evidence for one over the other. But essentially, if you keep your systolic over 110, they're going to do better. And then ICP management only if they're showing signs of herniation. We get this all the time where you'll have an old guy with a chronic subdural and the read will say something scary like signs of impending herniation, but he's awake and talking to you. Don't treat their ICPs. They don't have ICP issues if they're awake. Okay. Why we care about secondary injury? Causes yourself to die. You don't remember. Don't need to remember all this from second year med school. Bad things that we know about. Hypotension. Systolic blood pressure less than 90 millimeters of mercury has a 67% predictive value of poor outcome. If you combine that with hypoxia, you now have a 79% predictive of poor outcome. This is all in ED management. So that's why the most important thing you can do is intubate your patients and resuscitate them. So we're still back to our patient. We haven't gotten our CAT scan yet. There is what we basically classify our treatment into tier 0, tier 1, tier 2, tier 3. And tier 0 is a blanket statement for all patients that we suspect having a traumatic brain injury. And you look, it's pretty basic. It's all the things that we're normally going to do. You're going to intubate them. You're going to keep the head of bed elevated. You'll sedate them just so they can tolerate either intubation or treatments that are going on. Normothermic, normotensive, maintain a hemoglobin greater than 7, and just normalize your labs. Again, everything's normal. This stuff's all really easy. So we finally took our patient to CAT scan, and this is what we see. Anyone want to read it? Bunch of broken stuff. So the bottom row is looking at our bone windows. You can see all these skull fractures. Most indicative of really serious traumatic brain injury are vascular skull fractures or skull base fractures. He has a really high impact. The other thing that's very concerning on his CAT scan is he really doesn't have a mass lesion. If you look at that subdural on the top right of your screen, it's not that significant. It's really not impressive at all. But if you look at the amount of midline shift, it far outweighs the mass effect that you're seeing. So that's being caused by edema, and that's why this guy is going to have such high ICPs. So what do we do? Oh, sorry, skip ahead. He already had a dilated pupil. On our last slide, we saw that he was a little bit hypertensive, he was a little bit bradycardic. So he's showing clinical signs of Cushing reflex. We talk about the Cushing reflex all the time, hypertension, bradycardia. A lot of people don't understand why it's actually happening. So our brain tries to auto-regulate the amount of blood flow to the head. As your ICPs increase, your cerebral perfusion pressure is decreasing. Your brain's not happy about that. So it needs to increase sympathetic outflow to elevate your MAP so you can maintain your cerebral perfusion pressure. Problem is, your carotid baroreceptors have no clue why your blood pressure is now in the 220s, and it's not happy about that. So it's going to increase vagal tone to decrease your heart rate. Treatment is to treat ICPs. Don't try to treat your hypertension or your bradycardia. That being said, if they're about to code, you give them atropine. So here's our guy. He got all the things he needed to. He got some mannitol, he got some hypertonic saline. We took him pretty urgently to the OR. And you can see on the right what we did. We removed the skull on the right side of his head. And that basically allows room for brain to swell outwards. And you can see the improvement in midline shift there. Wait, no. There we go. There is a clinical term called muffin topping, and that is when your brain swells out so much around your skull. It's kind of hard to see, but it's a little bit flat on the tip, so I could ORA. But you can see the border of the skull, and you can see the brain just swelling out around it. It's about 20 to 50 centimeters. If your skull were intact, that's where your midline shift would come from. This is what allows it to expand. If you're wondering, I 100% describe this to families as muffin topping. Imagine unbuttoning your pants after Thanksgiving dinner and allowing your stomach to expand. Everyone understands that. All right, so we're talking about our interventions now. Tier 0, we already accomplished in the ED. We're going to move to tier 1, tier 2, and then hopefully not tier 3 because those are questionable at best. These interventions were created when we monitored ICPs alone. Our new way of monitoring is to look at both ICPs as well as what's called PbTO2, which is the partial pressure of oxygen in the brain. This is not your oxygen saturation. This is the actual tension of oxygen within the brain parenchyma itself. So there's an ongoing trial called the BOOST 3 trial that we'll talk about a little bit later. And it basically looks at patients in 4 categories. Type A is normal, where you have normal ICP, normal PbTO2. Type B is ICP elevation. Type C is oxygen being too low, brain hypoxia. And then type D is when you're just totally screwed in, everything's off. So Boost 3 gives us parameters of how we treat each of these targets. For group A, again, we don't have to do anything. They're in normal parameters. Group B is your ICP elevations only. So this is where you're going to do as tier 1 low dose mannitol, hypertonic. You can mildly hyperventilate to PCO2 goal of 35 to 40. If you don't accomplish your goal in tier 1, you can move to tier 2, where you give more mannitol and more hypertonic. You can marginally hyperventilate a little bit more. You can control the temperature a little bit better, and you can consider doing paralytics, but you're supposed to do a test dose first to see if they actually respond. Tier 3 therapies are controversial, mainly because a lot of them cause worsening of systemic complications. So they're not usually favored. Decompressive craniectomy is the one caveat to that. Hypothermia has been proven to be ineffective since this has been published. And ventilatory control of 30 to 35 is pretty detrimental as well. So we really try not to get to tier 3. This will be kind of interesting for the pulmonary people. So if your brain tissue oxygenation is low, the idea is you want to increase your systemic oxygenation. And the way you do that is increasing the amount of oxygen in your blood. So what do they recommend? Increase your FiO2 to 60% and leave it there. That's regardless of what your oxygen status or what your PaO2 is. And if that doesn't work still, well, then just put them on 100% FiO2. As you can imagine, rates of ARDS significantly higher in this group, and no one cares what your TBI outcome is if you're dead from ARDS. The other thing we do in this group is we transfuse them blood to a hemoglobin of 9. You know, that's not safe either. So that's why treating your PbTO2 is still somewhat controversial, and that's what the goal of Boost 3 is looking at, is if these treatments actually provide a benefit or if the systemic complications are a little too extreme for us. Type D, you're all messed up. You can read through this on your own, but basically you try your ICP strategies, you try your oxygenation strategies, and hope for the best. That was presenting Boost 3 data. There is a Seattle group that published these, and these are what never to do when you have both ICP elevations and PbTO2 decreases. You don't want to give continuous mannitol. You don't want to give scheduled hyperosmolar therapy. It's better to do intermittent boluses when you're showing ICP elevations. Steroids have been contraindicated for a long time in TBI. We don't use hypothermia anymore. We do use targeted temperature control, but you don't want to be hypothermic to below 35. Going below burst suppression, decreasing your PaCO2 under 30 is quite devastating. And then, yeah. So one of the things that we care about is how do we know what our MAP target is? We have the same MAP target for every patient, regardless of medical comorbidities, age, size, weight, right? But how do we know where we are on the autoregulation curve? So there's what's called static pressure autoregulation testing. And the idea is to determine if improving your cerebral perfusion pressure provides a benefit. The way that we do that is kind of fun. So first, have all your parameters being static. So you don't want to be changing anything else except for your MAP at this period of time. You want to record your initial MAP, ICP, and CPP. Those are the variables you care about. And then you increase your MAP by 10 millimeters of mercury for 20 minutes. And you can do that however you want. Fluids, pressure, and then you watch to see what happens to these parameters. So the idea is, if you're between the two asterisks and you have correct autoregulation, as you increase your cerebral perfusion pressure, you're now your brain doesn't want to increase cerebral blood flow. So it's going to decrease the size of the arteries, and that should in turn decrease your ICP. So basically raise MAP, decrease ICP if you're autoregulating correctly. If you're not, and you have impaired autoregulation, then as you increase your perfusion pressure, you're just going to increase your ICPs alone. If that slide didn't make sense, this one makes a little bit more sense. So the top one is intact autoregulation. As your arterial blood pressure increases, your cerebral perfusion pressure increases, your ICPs decrease. As you fall off that curve, then you're going to have continued increases in your ICPs as you increase your perfusion pressure. Unfortunately, a lot of TBI patients have impaired autoregulation, and just as you increase blood pressure, they're just going to have increases in ICP because they can't regulate the constriction of their blood vessels appropriately. So the idea is you do this MAP challenge, see if they have intact autoregulation, and see what is the ideal MAP and cerebral perfusion pressure for them. We talked a little bit about hyperventilation. The idea is as your PCO2 goes down, you constrict vasculature in your brain. Less stuff in your brain should decrease ICPs. And we use a mild degree of hyperventilation. That's why our PCO2 goal is about 35. We really don't want to go below that. Anything lower starts causing hypoxia in the brain. You have increased risk of seizures, arrhythmias. And if you're going to hyperventilate, it's a bridge to future treatment, meaning it's as they're herniating and you're preparing them for the OR, or as you're getting your hypertonic ready. This is not your treatment of choice. It's just a fallback. If you look at perfusion imaging or serial blood flow imaging, you can see the difference at a PCO2 of 35 versus a PCO2 of 26 of how little blood flow that brain on the right is getting. And that's why it's so detrimental. So this is, again, only a bridge therapy. Otherwise, keep them normal. When do we use an ICP monitor? So all the studies have shown that sustained elevated ICPs over 20 to 22 intubatable have worse outcomes. So it makes sense that all CBIs should have ICP monitors, right? Yeah, should be. So when do we put it? So most importantly, do not replace the physical exam, still monitor your patient. And then our indications are anyone with a GCS of less than 8 and structural brain damage on CT. It's not the intoxicated patients that are GCS of 5 just because they're really drunk that have totally normal head CTs. It used to be in the past, but that's changed. And also consider for patients who are GCS of over 8, but they're going for prolonged surgeries. So this is your classic kind of moderate TBI who's about to go to the OR with ortho, and they're going to have significant blood loss and blood pressure changes. We'll sometimes put a preoperative ICP monitoring. This is how we put ICP monitors in. This top picture is how you place an EVD or external ventricular drain. That's a catheter that goes through parenchyma into the ventricle. The bottom picture is how we put in a fiber optic monitor that gets screwed into the skull, and then a small fiber optic wire goes through that and just sits in the parenchyma itself. Here, if you ever walk through the ICUs, this is what it looks like. CSF flows into the collection system. We change the pressure to determine how much is actually being drained through it. And then these are the fiber optic monitors that we use at Kings County. The brand name is Raumedic. And that measures not just ICPs, but also PbTO2 as well as brain temperature. We put them in at the bedside. Not really a big deal. We have a drill that looks like a baseball drill. That got messed up. Just go to the next slide. The reasons why we choose one over the other. EVDs are the gold standard. They're both diagnostic and therapeutic, meaning that you can not only measure ICPs, but you can treat ICP elevations by draining off CSF. They don't drift over time. They're more accurate. Problems with them, they're slightly more complicated to place, especially when there is midline shift or mass lesions. They have much higher rates of complications, including hematomas and infections. But again, they are both diagnostic and therapeutic solutions for birth. Benefit of fiber optic monitors, much easier to place. Also, now our multimodality monitoring allows monitoring of more things, including the oxygenation and the temperature. What we can do is we can place both. We can place both an EVD and an ICP monitor if we want all the data as well as the therapeutic benefit of it. So the only randomized control trial we have is a study called the Best Trip Trial. I want to come back as a person who names clinical trials. And it was considered so unethical that we couldn't do in the United States. So instead we went to Bolivia and Ecuador. And what we did there was we took a group of patients, all had severe traumatic brain injuries, and we categorized them into ICP monitoring versus imaging and clinical exam alone. And they created this kind of protocol. And what they found was that there was absolutely no difference between ICP monitoring groups and the clinical exam and imaging model. They had the exact same mortality as well as long-term outcomes. However, if you look at the protocol that they use for the imaging and clinical exam, it's not really replicable. These patients got multiple CAT scans every day. They had one-to-one nursing care. They got amazing care that we don't have actually in the United States. And that's why, unfortunately, we still need ICP monitors. Like we said, an ICP monitor doesn't neglect your clinical exam. It should be used together. But they did such a good job of monitoring the neurologic exam so closely that they use that almost as a surrogate for ICP measurement. And that's what we can do while we're waiting for an EVD to go in, or if for whatever reason it's not going in. Boost 2 was a study that looked at ICP monitoring versus ICP monitoring and brain tissue oxygenation monitoring. So currently brain tissue oxygen monitoring is still being studied. We have nothing that shows that it works. Boost 2 is just a feasibility study. And that has shown some promise of better outcomes with the oxygen monitoring alone. Boost 3 is currently ongoing, so I'll update that in a couple of years. All right, now how do we treat ICPs? I don't know how, okay, so okay. All right, everyone knows mannitol, we say it all the time, give mannitol. How does it actually work? It's an osmotic, it creates an osmotic gradient, pulls water out of the brain, similar to when you put salt on a snail, causes the snail to pop. And then it decreases sodium and water reabsorption in the tubule, so you actually pee that fluid out. Don't give in to people who are dialysis dependent. It's not going to be effective. They'll just absorb all the water. And then you want to be careful of kidney function as well. Biggest thing with this is because it's a huge osmotic diuresis. So especially since we're worried about hypotension, make sure you're replacing the fluid back so that they don't become hypotensive with mannitol. It works pretty quickly within 20 minutes, lasts for a few hours. Dose usually between 0.5 to 1.5 grams per kilogram, sorry. So just remember 1 gram per kilo and you're fine. You want to hold it when your osms are 320, or if your osm gap is greater than 20. You can get this on MDCal. But basically, there's a lot of different things that can go into our osms, especially when they have elevated sodiums or if they have an elevated alcohol level. And that may adjust your dose with mannitol. And then you don't want to give repeated doses. That can actually cause a reversal of the osmotic gradient and then cause rebound elevated ICP. Hypertonic saline is the other thing you always hear. Again, it causes fluid shift out of the brain. It improves cardiac output as well, so you don't have the same effect that mannitol does, where it's causing hypotension. And there's all these like bench research possible improvements with hypertonic saline, but none of these have ever really played out yet. So hypertonic saline comes in a million different concentrations, about 2%, 3%, 7%, and 23%. All the studies have shown that bolus dosing is favored over continuous infusions for ICP management. If you're just treating hyponatremia alone, continuous infusions are fine. Onset super fast, onset to 12 hours, and then your goal sodium is going to be 155 to 160. Everyone always asks, which is better, mannitol or hypertonics? Hypertonics, you're going to have more sustained ICP lowering. It works faster. And you, most importantly, don't have the hypotension associated with mannitol. So just give salt, be salty. If you ever were wondering what the osm and sodium concentration of everything actually is, I love the 23%. Your sodium concentration is 4,000 milliequivalents, and your osmolarity is 8,000, which is why it works so well. All right, the thing we also care about, most importantly, is your cerebral metabolic rate of oxygen consumption. Basically, how hard is your brain working? So our CMRO2 is dictated by the number and frequency of neuronal depolarization. So you guys remember your sodium, potassium, ATPases in the brain? How often those channels are opening is going to determine your consumption of oxygen. 60% of the CMRO2 is used to make ATP to create neuronal electrical activity. So what that means is you put someone in burst suppression and their EEG is flat, you will decrease their CMRO2 by 60%. So barbiturates and propofol cause profound decreases in CMRO2, which is why they're so good at decreasing ICP. There's no benefit of going beyond burst suppression. That remaining 40% is we keep our cells alive. So just stop at burst suppression. That's what it's important. Propofol, as you can see, dose dependent, decrease in electrical function. That basal function is the remaining 40%. You're never going to get that down with propofol. Causes significant decreases in cerebral blood flow, and that's why it works so well with lower ICP. Next thing we're still on CMRO2 is fevers. We will freak out about fevers more than anyone else. And the reason why is for every 1 degree Celsius you are febrile, there's a 7% increase in CMRO2. And if you go above 40 degrees, you just start having neuronal cell death. This applies to the body also, so really everyone should care about fevers. So you can see how much your metabolic rate goes up as your temperature goes up. Every brain injured patient will get febrile within the first 24 hours. If you're putting a central line in, put a cool line in. They will get febrile, we will use it, I promise you. Please place cool lines. You don't want to make them too cold. Cold is bad also. The polar trial came out a few years ago. No benefit of hypothermia. That's anything below 35 degrees. That being said, normothermia is where it's at. So just keep our patients normal. Again, everything normal. Blood sugars, super, super important. So people will hear me freak out when someone's blood sugar is high and they're like, who cares? That's the least of their problem, but it's not. Blood glucose goal between 120 and 60, strict blood glucose, super important with traumatic brain injury. You can see the Glass outcome scores and their 6-month recovery significantly drops off as their blood sugar goes higher. This is an average over hospitalization. And that blue line of blood sugar is around 120 to 160. So we expect a much tighter glucose control than we care about for the regular ICU population, where we're okay with less than 180. I had to throw this in here. Ketamine's good. Don't worry about it. Everyone thinks that ketamine can cause ICP elevations. It doesn't. And then think of other reasons as to why your ICPs might be getting higher. There's a lot of reasons why ICPs might be high, aside from just brain swelling alone. So you need to do a little bit of ICP detective work. So find out, is your ICP monitor actually working and it's accurate? Are there any changes in neurologic exam that should prompt a repeat head CT because maybe they do have a new hemorrhage or worsening edema? Are we doing anything to the patient to make their ICPs actively higher? Are they being suctioned? Are they being turned or bathed? Are they laying flat for no reason? Are we currently trying for the past hour to put a IV line and we're just hurting them? And then any patient condition factors. So we talked about fever, hypercapnia, pain. If they're trying to poop, your ICPs will always go up. Other things that other people forget about is constipation. As your intra-abdominal pressure increases because you haven't pooped in 7 days, your ICPs are going to go up as well. And that's a really stupid reason to have ICP elevation. So put everyone on SONA. And then urinary retention, same concept. And then don't forget about seizures. A lot of patients will have being status epilepticus, but not convulsing. And then we'll not think of that, and that could be another reason for their ICP elevation. What we know is harmful. Albumin is bad for resuscitation. Crash trial has showed us that high-dose steroids increases mortality in traumatic brain injury, and then hyperphagia. Oh, I actually made it on time. Yes. Okay. I wanted to put more slides in. I thought I was going to get probably long. So post-intensive care syndrome is a relatively new phenomenon that we're learning about, and it's essentially like a PTSD after being a patient in the ICU. And we often I don't know if we don't care or we don't realize how traumatic being a patient is, as well as how traumatic being a family member. And there's about a 62% rate of depression, anxiety, and PTSD following prolonged ICU admission. And families just called success. And the risk factors are kind of interesting. Poor communication with staff was rated as the #1 risk factor. So not giving families updates, not understanding what they're being told, or just having like rude interactions with family members has always been stated as the most their highest risk factor. It's the not knowing what's happening. And sometimes we avoid talking with families because we don't know what's happening or we don't know where things are going yet. And that's okay to tell them. We can say, hey, we're worried about this, this, and this. We're not exactly sure why this is happening. This is what we're doing to work it up. We'll keep you updated. And that bit of reassurance makes a huge difference. Interestingly, being in a decision-making role creates a lot of anxiety, and especially in the US, when they looked at the US compared to other countries, we believe in, complete patient autonomy, right? We go to a family member, hey, mom needs a trach. You either want to kill her or give her the trach. What's your decision, right? And I need that decision within 5 minutes. You have no time to think it over. Whereas more paternalistic medical societies, where it's more of, this is what we're recommending. We think this would be the best thing. they had better outcomes because that decision making wasn't on them. They didn't have the stress of making the right decision. Lower educational level, unfortunately, higher rates to do with it. And then obviously how severe your illness is. If you're only spending a day in the ICU because of, mild decay, you'll snap out of it better than someone who's been in the ICU for 6 weeks or so. One thing that's really cool, and I want to get started here, is something called ICU diaries. And what it is very simple. You give either the patient or the family the notebook, and anyone can write in it. If the patient's able to, they write in it. If not, the families or even the medical staff, nurses and doctors. And we put the date on, like a regular diary, put the date on top and be like, hi, you're admitted for this reason. This is what we did to you today. Or, today was your first day on a spontaneous breathing trial. Today, your pneumonia got worse. Whatever it is, positive and negative. It allows the families and the patients to look back through it. And that kind of active role, families especially have found incredibly rewarding. What's interesting that we don't think about is our patients are sedated, but they can still hear us. And a lot of times they create these false memories or false perceptions of what happened. Think about when you've ever been in a somewhat intoxicated state, I know no one has, you may not fully understand what's going on, right? But you hear bits and pieces of it and you may be a little bit confused. So they have these false traumatic memories of what they think happened. But if they can go back and be like, oh, that's what was going on, it's very soothing. Finally, the other thing is, remember, our patients can hear you. So don't say stuff in the room like, oh, they're dying or no one cares. Those mean things that we say, we have to assume that they can hear us and they can understand us at all times. And then finally, my last thing is your patients who are sedated can still feel. So before we do invasive procedures, use lidocaine, numb them up, give them sedation. Imagine you getting a central line while you're fully awake, right? That's evil. They can feel you. That's why they're pulling away. That's why their blood pressure is going up or they're getting tachycardic. They can feel you. Anyway. There's supposed to be no more slides. Anyway, if you listen to nothing else, just remember, keep their blood pressure up, give them oxygen, and be nice. That's it.